And welcome to Gilda's Club Kansas City's Caring Conversation, beginning the conversation around advanced care planning with Judy Waechter with Good Shepherd Hospice. Go ahead, Judy.
Hi, thanks first for tuning in to this afternoon and bearing with us while we get more comfortable with doing these. Haven't been doing them for a little while, so I'm a little slow. This is the workbook that I prefer to use when teaching about advanced care planning. It is one that is utilized through things like the Conversation Project and part of national grassroots efforts like National Healthcare Decisions Day, which is actually this week, April 16th. So this is my busy time of the year for doing this presentation, which is pretty much on hold right now because of all of the physical and social distancing. So the Caring Conversations workbook was put together by the Center for Practical Bioethics here in Kansas City. Their website is on the inside front cover of the first page. I think we sent this out, and if not, we'll make sure that you know how to access all of these resources. The Center for Practical Bioethics works internationally on ethics in healthcare. And it's not just about advanced illness or serious illness or aging or dying or things like that. It is about ethics in healthcare. Should we be letting children play contact sports, knowing what we know about head injuries? Should we be dealing differently with the effects of gun violence in our healthcare communities, in the industry? How do we balance the pain opioid crisis with those who have chronic pain? So they deal with all sorts of things. They're an available resource to you, lots of good information, podcasts on their website. And this particular one is about doing your advanced directives, your durable power of attorney for healthcare, which has really nothing to do with dying or being old or having terminal or serious illness. If you're 18 years of age, you need a DPOA for healthcare. That's just the bottom line. And the reason is for all of the changes that have come about in healthcare. You know, it used to be really clear. We knew if you were alive, we knew if you were dead, and there really weren't many choices in between. Okay. We also knew that most of us would die a fairly sudden death from a heart attack, a stroke. We'd have an accident or an illness and fade away in just a few weeks. But with the changes that came with emergency medicine and medicine technology that we got from the battlefield clear through, Vietnam and things like that, the invention of the newer birth control methods, all of a sudden we were able to keep people alive after traumatic events with chronic serious illnesses. We were able to prevent infections, and we're not going to get into some of these topics, but when does life begin, much less when does life end? It wasn't clear cut anymore. And there's a lot of very personal feelings that come into making these decisions. These are not all black and white numerical decisions. We all have the right in this country to seek health care at whatever point we want to. You don't have to do any prereqs to come in and see your doctor. We'll treat you as you show up. And because of that, we came up with something called the Patient Self-Determination Act. And the reason that this came about was because of cases that were really big in basically the late 80s and into the 90s when all these changes started to come about. And one of the most prominent one was Nancy Cruzan, a young woman from here in southern Missouri area who happened to work at a daycare center. And this was at a period of time when everybody wasn't on their cell phone all the time. And when you took a lunch break, you went to like a lunch room and people sat down with their sack lunch because there wasn't the takeout and delivery that there is now. So you were there with these people and you communicated with your coworkers. And with some of the other cases that were going on nationally and the changes in the news media, being able to start your day with Good Morning America and end it with Nightline, all of these things suddenly also became a changed way of sharing information. So medical technology changed, and so did our ability to present information and to share it, whether we should or not. So now, instead of these being personal family situations, we had the news media sharing very intimate details about people's families and their lives, as well as their medical conditions. And in the case of Nancy, she was in an automobile accident, sustained a traumatic brain injury, was in a persistent vegetative state. These are not terms that are used lightly. There's all sorts of checks and balances in the healthcare system of different evaluations and lengths of time that have to take place between these. And when it was evident that she was never going to recover, her family made the decision to withdraw heroic measures, artificial life support, and allow a natural death for her. However, the news media and members of the community got very involved in it and shared their opinions quite publicly about it. The case ended up going all the way to the Supreme Court, and it was the conversations, the caring conversations that took place between Nancy, a young woman in her 20s, and her coworkers at the daycare center about these other cases that had been in the news, about what they would or wouldn't want, what quality of life meant to them, what being alive meant, what kind of treatments and interventions they would want. And when they were able to share that testimony, the Supreme Court ruled in favor of Nancy's family, and artificial life support was withdrawn and allowed a natural death for her. As a result of that, people, us, came about and said this was horrible and this never should have happened. This was a personal event. So if this were me, I should be able to pick who speaks for me if I can't speak for myself. And I should be able to determine what medical care I do or don't want to accept. And legislation was proposed and Congress passed in 1990, affected the Patient Self-Determination Act. And that guarantees all of us the right to choose who will speak for us if we need help through the healthcare system, and to say what, to elect what our choices will be, whether that's now or later. So what we want you to do is to think about these things and talk about them. And I'm not going to read the book, but I do want to walk you through it a little bit and hope that you'll take time to utilize this on your own and make sure that you have the documents in place that you need. It's
Judy.
always...
Judy, can I interrupt you?
Sure.
Someone talking behind you?
Someone isn't muted.
Everybody is. There we go. I got it. Okay, sorry guys.
That's good. Thanks. So what we want you to do is look through the book, think it through, and get your paperwork done and in order so that if and when you need assistance, you have what you need. But it gets confusing. There's a lot of medical terms out there, and sometimes we get misinformation and think that we're having to commit to a lot of things that we're really not. So at the start of this, I'm going to assume that right now you kind of have an idea in your head of who would be the person that would help you out if you needed help navigating through the healthcare system and weren't able to do it all on your own. And I want you to kind of keep that in the back of your mind as we're talking through this workbook. The first thing I want to say is that you cannot possibly come up with a plan for every conceivable medical event you might encounter. It's impossible, and we're not asking you to. All we want you to do is talk early, talk often, so that the people that will be responsible for helping you if and when you need it know what to do. This is to ensure you get what you want and to make it easier on your friends or your family that you choose to help you know what they're supposed to do. The first thing we want you to do is start thinking about where you are in your life. You know, for me, I don't worry about certain things like Alzheimer's. I don't worry much about diabetes. Those don't run in my family. No family history of those. We're big on cancer and heart disease. And with my own history, I know that those are panning out to be the issues that I'm going to have to keep an eye on. So those are the things I start thinking about. And where do you want to end up? I have yet to meet anyone whose goal was to be in need of 24-hour-a-day long-term care, nursing home care, living in a nursing home as soon as possible. I mean, quite frankly, most of us try and avoid being in a nursing home. It's for those that are the more frail and weak of the population that need 24-hour-a-day assistance and supervision. And luckily, less than 5% of seniors will end up in long-term care. But for the rest of us, we kind of have to have a plan so that if and when we need help, we have a plan for how that's going to work out. Many of you may be in a situation where you have multiple family members and it's just assumed that you'll all take care of each other. But, you know, sometimes, especially with my experience being a nurse and working in rehab, I prefer end-of-life care. That's the area of healthcare I specialize in. But you look back over the years at the patients and the families you've dealt with, and typically what you had was one family member in the bathroom with a nursing assistant saying, oh man, you got to get me where I can take care of all this stuff. I don't want to go home and have my son cleaning me up. And then you had the son outside the room talking to the nurse saying, God, I'll do anything my mom needs. Just don't make me do that. They both wanted the same thing, but the door was closed in between and neither one of them was communicating with each other. And I own adult children, but I'd prefer not to live with them any longer than I had to. And I would prefer not to be a burden on them. And I've been fortunate to be able to put a little bit aside in case I need some help at home, but it's going to depend on how much help I need and for how long I'm going to need it. So I do have two girlfriends that we want to be the golden girls and, you know, end up down in Florida and all those wonderful things. But in case that doesn't happen, I need a backup plan. And I've learned that hope isn't enough of a plan. So think about what your options are. What do you want? What are they willing and able to do for you? Are you willing and able to live that way? What concerns do you have about what level of need do you have? And start thinking about these things and having some conversations, because you might be surprised at what you think everybody wants and what they're really willing or wanting to do. And then we want you to continue the conversation thinking about things like quality of life and what are your styles. You know, most people fall into either an A, a B, or a C column. We got our type A's over here. These are the people that say, do not let me die. I don't care what you have to do, keep me alive. I got a deep freeze out in the garage, and if something happens to me, put me in the deep freeze, and then if they come up with a cure, thaw me out and see if you can bring me back. But for God's sake, do not let me go. And then we have the complete opposite over here, the C's. These are the ones who, you know, medicine's all a bunch of flakes. It's all a bunch of quacks. Never take a flu shot. Never go to the doctor. If I ever get anything, I'm just going to, you know, cash it all in. And I'm going to go on a cruise up in Canada or Alaska. And, you know, the bears will eat me. No big deal. But most of us fall somewhere in between those two extremes. Most of us are kind of in the B category. We will try things. We may not do the perfect diet and the perfect amount of rest and exercise and glasses of water and all of the things that would be perfect care, the owner's manual, if you will, for our bodies. But we try. We make an effort to do quite a bit of it. And if something goes wrong, we're willing to treat it and to try and make it better. But knowing that is very important because it helps not only the person that you have asked to be your spokesperson, your agent, know what you would have wanted, but it's important to keep in mind as you're talking to people that you think you want to have as your agent, because if you are, for example, assuming that your spouse will be your agent, if you're married to a type C and you're an A or a B, that may not work out real well. And if you're a B, you may not like the care that A person is going to insist on you getting, in which case that spouse or that certain sibling may not be the most appropriate person to be your agent. You want the person who's going to fight for you and do what you want done, what you need done. And it's both sides, who you ask and are they willing and able to do what you're asking. If you have adult children that every time you try and talk about your own funeral plans or grandma and grandpa's funeral plans, and they're going, la, 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 don't talk about it, you're never going to die, Mom, they've just given you a pretty good clue that they're not comfortable with a lot of this responsibility. If you have an adult son and it's his wife that takes the cat to the vet to be euthanized, they're kind of telling you how they feel about these serious things. If they don't want to be present, if they don't want to go there, these are probably not the most appropriate people to put in place of those decisions. And we want to be mindful of that when we're asking that of others. So as we're talking about some of these things, we want to think about some of the serious things, which right now are pretty prominent in the news. Unless you've been under a rock, you're pretty familiar with some of the issues that are going on right now about some of the serious things that are being talked about out there. And that goes straight to this finish line. There's most of our life will happen between the beginning and the end. But when we start talking about heroic measures and artificial life support, like we are right now with COVID, it changes things up a little bit. So I want to talk a little bit about that. For instance, it talks here in Caring Conversations about things like breathing and whether or not you would want a ventilator. This is not a yes/no question, first of all. This is a situational question. First of all, is the person even in a situation where it's even being brought up? And then what situation are they in? You know, my parents died pretty young, and I was durable power of attorney for both my parents. And my father had heart and lung disease. And in the early stages of his disease, he was on and off the ventilator several times, not just for infections, but he had some pretty advanced and somewhat radical lung volume reduction surgery and did pretty well from it once he lived through it and got an extra 7 years out of it. Part of that time, he was even on room air. But fast forward 7 years to the end of his life. We weren't going on the ventilator again. He was so weak and frail and compromised that he never would have been able to come off of the ventilator. But we never had to write down no ventilator. It was the conversations between him and I and making the decisions about where we were at each stage. And for the majority of the time, it was just conversation and me helping him, because he was able to make his own decisions literally up until the last 24 hours or so. So when we look at these things like breathing and ventilators, first of all, I'd like you to think about the last time, may have been a while, that you were out shopping, you know, at Target or at the grocery store or at some public event, a restaurant. You know, how many people did you see on ventilators? I'm going to challenge that most of you have never seen anyone out in public on a ventilator. Maybe an interview with Christopher Reeves after his accident a few years ago, or the muscular dystrophy telethon that used to happen every Labor Day with Jerry Lewis. You'd see a young kid with muscular dystrophy that was on a vent come out. We don't see them in public because it's not normal. These are artificial, heroic measures when something is breathing for you. And the only people who can be on a ventilator are two categories. They either have such severe disease state, whether that's from a spinal cord injury up high like Christopher Reeves, or maybe it's a disease like ALS or muscular dystrophy. They're able to be on it because their body is so weak and compromised that it has no resistance to fight the ventilator. For anyone else, COVID or otherwise, accident or whatever, even if it is just to temporarily lower the body's needs and let some balancing take effect after an accident to stabilize, that person is going to be sedated because no one is going to lay there on a ventilator. It's impossible. This is like putting a leaf blower down your throat and forcing air into your lungs. You would fight it, or we call it bucking the vent. So anyone who doesn't have an advanced disease or illness is going to have to be sedated to be on it. If you have to be on it for a couple of weeks or longer, we are going to go in and surgically do a tracheostomy, the opening in the throat, at which point the decision has now been made that you will not eat and you will not drink and you will not talk, because now the machine will be hooked up to that, which means that you won't be able to eat, drink, or speak. So there are big life changes that come with the ventilator. It also will not reverse diseases. It will not cure cancer, ALS, a stroke, any of those things. It is meant for a temporary pulmonary function support while the body heals enough to take it back over on their own. So I'm not saying that anyone should or shouldn't have it, but we need to think about when is it appropriate and when is it not. In advanced illness, advanced disease states, at end of life, or in someone who's very frail, very elderly, it may not be appropriate. And the first creed of healthcare is to do no harm. So sometimes we have the capacity to do some things, but do we have the right situation to utilize those? And that brings up things like tube feeding. And this one is very difficult because food, you know, we have a lot of connections to food and drinking. And if you have tube feeding, that was meant to supplement your body while healing took place until you could consume calories again normally. I'm not talking about IV fluids for a few days after a surgery or an infection to help stabilize you until you can take things orally again. I'm talking about the pleasure we get from eating and drinking. You don't feel that sensation with a tube feeding. A tube feeding is to allow the body to heal, to support the body until it can do those things on its own. And in some cases, like Nancy Cruzan, because they were in a persistent vegetative state and couldn't eat, but we needed to give it the body enough time to see if there was going to be any chance of recovery. So during those initial 6 months, yes, we did what we could to support the body. But we know that artificial feeding and fluids are actually not interventions that are helpful for people that have advanced life disease processes. In those cases, it causes more symptoms and problems and shortens life. In fact, tube feedings cause a lot of problems. No COVID, just allergies, I promise. Pneumonia, bed sores, vomiting, lung congestion, diarrhea, all of these are common problems with people that are on tube feeding, especially when they have advanced illness and disease states. It will not reverse a heart attack, a stroke, Alzheimer's, any of those things. So we have to use it very diligently and very carefully, which means conversations. Caring conversations, talking early and talking often to make sure that we're making the right decisions. And I would encourage you not only to include your key support system, but your physicians. They're your mechanics for your body. So getting their insight and their input, what will happen if I do this? What will happen if I do not do this? It's not a question of should I not? What will it look like if I do? What will it look like if I don't? What will it really change? Because you can't make an informed decision until you've truly been informed. And we want to have very real conversations with our physicians about these things ongoing. I don't think I'm surprising anyone here, but the reality is we are a temporary body. We are not meant to be here indefinitely. We will all die from something at some point in time, even though none of us are in a hurry to get there. Kind of like Woody Allen says, he's not afraid of it. He just didn't want to be there when it happens. I kind of subscribe to that a little bit too. But we need to think about our worst case scenarios so that we can make a plan to avoid those and in effect get what it is that we really do want out of our health care and our disease state and those type of things. If you flip over, if you're printed out the book, but either way, I'm going to take you fast forward a few pages to actually look at the form because I want you to be really comfortable with it, okay? The first thing I want you to notice is that this form has the word optional next to your Social Security number. Same on the back. It has optional under the line for social. Do not ever put your social on this. That will be coming off of these forms, but it is not needed. We do not need it. We do not want it. And we want this form widely available, but we don't want identity theft widely available. So no Social Security numbers, not even the last 4 digits. We don't need it. We do need your name, okay? And your legal name, what it will say on your insurance card, those kind of things. What this form allows, a durable power of attorney for healthcare. It's important to understand when we start talking about advanced directives and we start talking about living wills. A living will is a form that you fill out that says, how you want your end-of-life care to be. I want heroic measures. I don't want heroic measures. And that's it. It does not assign a durable power of attorney agent. You still have to have this form, which is free. You don't have to go to an attorney. It's a free piece of paper. You can get it notarized at your doctor's office, at your bank, whenever you can get back into the real world. But all you need is this one piece of free paper and have the conversations. The living will only addresses how you want to die. And once you die, it does not allow anything after that, like release of your body to a funeral home, those kind of things, which can cause big problems for your family because you said everything was taken care of and it really wasn't because you didn't understand the forms. And some of the things that we're going to talk about are doctor's orders. An attorney can't give a physician order, only a physician can give a physician order. So what this form allows is for the person that you've chosen to speak for you, if you need their help or can't speak for yourself, to give consent for a procedure or a treatment. My mom was a collector of cancers, and a couple of times she was in bad situations where she was really ill, sometimes related to symptoms from treatment, once related to an infection. And during that period of time, I stepped in and signed paperwork for her. But as she recovered and her thoughts and thinking cleared up, she took back over again. This form doesn't allow some crazy relative to crawl up out of the woods and come up and claim that you're nuts, put you in a nursing home under lock and key and take your money, your house, and your car. It does not work that way. This is for healthcare only, has nothing to do with DPOA for finances. This is for medical care only, and it is only if and when you cannot speak for yourself or you ask for their help. My mom needed her medical records from her first chemo for her oncologist with her fourth cancer, and she got good returns on her investment. I mean, we're talking about a 25-year span here. But at the time that this oncologist needed those original records, my mom's in the hospital going through a barrage of tests and workup to prepare for a very extensive surgery, and there's no way she can deal with getting those records, but I could. I was DPOA for healthcare. I can electronically send this over with a release of information request, talk to them on the phone. Nope, don't need them right away. Well, good, because they're on microfilm and it's going to take a few days. Not a problem. We won't even see the surgeon or see the oncologist for a couple of weeks after the surgeon's done and discharges her. Well, give us 2 or 3 days. We'll have them ready in manila envelope at the nurse's station. Just bring picture, photo ID when you pick them up because you'll have to sign for them. Easy peasy, took care of it, delivered him to the oncologist. By the time she went for her first oncology appointment post-surgery, they'd already reviewed the records and knew what their treatment options were. And at this stage of the game, with all of the HIPAA and all of the security that has been built into healthcare because we asked for it, you cannot get your teenagers' records. So what if they're a senior in high school? They turned 18. You can't even get a printout of their pharmacy records to do your taxes. At the age of 16, a child has to sign a form in the doctor's office authorizing who the physician's office can release information to in their family. We have all of these security and safeguards built in, and the onus is on us to make sure we have the correct documents so that when we need help, people can actually help us. This allows people to give consent or withdraw your participation even in a clinical trial. It is to make necessary arrangements to move you between different facilities so you could be in the hospital. Maybe you're in an accident in a rural area and you get transported to a city area, then you need to go to rehab, home with home health, outpatient therapy, all of those things. This allows that person to move you around and to sign and get the paperwork and the consents and all of those things done to help you if and when you need their assistance. It allows them to authorize the receiving and sending of information, like I said, described with my mom in the medical records, move you in and out of even a state institution or across the state line, which in this area is a big deal since we bounce back and forth between Kansas and Missouri providers all of the time. You can even take legal action if you needed to. You can make decisions about tissue donation, organ donation, autopsies. And the last one, which could be incredibly important in the case of Alzheimer's and dementia, this free piece of paper allows that a person to become your guardian if you become incapacitated. If you have not done this free piece of paper, and you need to do that, you will have to go through the court system and you will have to pay an attorney, and it will take weeks if you're lucky, typically months, and the court will assign someone. And frequently in the state of Missouri, that is a public administrator. You don't have to have that. And even then you may not end up, if they do assign a family member, the one that you wanted. So we want to make sure that we have these forms in place when we need them. And then we list the agent, the spokesperson's name and contact information, and you can list a backup. I happen to have one of my daughters as my primary. She and I just happen to communicate better, smoother. So she's the one that's on there, and her life is in a place that even though she hasn't lived in the state or even in the country for the last few years, we can communicate easily by text and things like that. So it works out fine. Things may change in the future, but it works out. And then I have a sister who is my backup. And again, things are fine in her life and her world right now. So I'm not putting an undue stress on anyone, and really don't have a lot of big issues. Although I can tell you, I have had to activate my durable power of attorney for healthcare in the last few months because of some issues that came up during some medical treatment that I was going through. We want to make sure we use legal speak. So for instance, if you were going to list your daughter and son-in-law as your primary agents, you would not write Jane and John Doe, because in legal speak, and means both, and you would have to have Jane and John. But if you add the word or, Jane or John, or you can even write Jane and or John, then either one of them is fine. But if you want to put a couple like that, you need to use the word or in there so that you haven't boxed yourself into a corner that you can't get out of. You want their current information so that we can contact them. I want you to take a step further on your phone. Under your ICE, capital I, capital C, capital E, in case of emergency contact, put your durable power of attorney and their phone number. So when I stumble upon you after a car wreck and we pick up your phone and hit that emergency button that unlocks your ICE contact, how cool would that be if it's actually the person that can authorize treatment and care for you? It would help us tremendously in the healthcare industry. And then you're going to get it witnessed, signed, dated, and notarized, which can be done for free. You don't have to have anybody with you, because when it's getting notarized, all you're notarizing is that you are who you say you are. So for mine, my notary is just saying, yep, that's Judy Waechter. I checked her driver's license, I looked at it and at her ID, and I confirmed it was her, and I notarize it. Now in the state of Kansas, and as long as you do your durable power of attorney based on the rules and regs of your state, it's good in any state in the country. In Kansas, you actually don't even have to have it notarized, although we'd really recommend it because anything with a notary is going to carry more authenticity. But in Kansas, you can just have 2 adults be your witness. In Missouri, it does have to be notarized. And this is different than a declaration or advance directive where you are saying what your wishes are. If you're just talking about what you do or don't want, frankly, you could write that on a paper towel and we'd take it. But to appoint an agent, a durable power of attorney for healthcare agent, we have to have it in Missouri legally notarized, and we'd actually prefer that you did that in Kansas too. And then we want you to do a couple things. We want you to make about 1 million copies of this, okay? And I don't want you to put it in a safety deposit box or with your attorney, because unless you carry your attorney and your bank with you everywhere you go, that's just going to guarantee that no one can get their hands on it when they need it. Make sure that your agent has copy, the people you live with have copies. If you've got a good neighbor, give a copy to them. Keep a copy in a Ziploc bag in your freezer. Tell everybody it's there. Someplace where it can be grabbed in an emergency, we'll know where it is. Put a copy in your glove box. When you wreck your car, you usually bring the glove box with you. There's a link at the Center for Practical Bioethics where you can access these workbooks for my directives that will download it to the cloud, and then you and your agent can access it with your phone easily. Make sure all of your doctors have copies, your heart doctor, your primary care, your allergist, the left eye doctor, the right eye doctor, your whatever physicians you see, everyone needs to have a copy of it. And then put a copy with your tax returns. And that's for a couple reasons. One, you do taxes every year. That'll remind you to look at the form and make sure that the names and contact information, the phone numbers are all current and accurate, and that something hasn't changed. You know, if you got divorced, you probably don't want your ex to be your durable power of attorney anymore. Although in a lot of cases that still happens, but it should be looked at, and you want to make sure that it's still up to date, because you can change this as often as you want. Ben Franklin said 2 things were guaranteed in life, death and taxes. Well, taxes got April 15th, death took the 16th, National Healthcare Decision Day. And then on the back of the form, this is optional, but I really want you to take that through, okay? If you don't want to do the back, just put a big X on it, that's fine. But it only asks you 2 questions. And these are incredibly important things for you to think about in this whole process. And the first one is about determining what are your quality of life indicators. And it says, you know, if I have a condition that I'm going to die from soon, or that I have such disease or damage that the hope of achieving a life that is reasonable quality to me is no longer there, then I don't want life-sustaining heroic measures. If I can't function at a certain level, it's okay to let me go. All right, so what is that certain level for you? What is your quality of life indicator? It's different for all of us. You know, I want to be able to speak and engage with other people and recognize other people and participate in my life. I want to know what's going on. I don't want to just be maintained for time on the clock. Flip the body, change the disposable undergarment, and pour a tube of feeding down the tube. That's not living to me. And I've had people list different things in this. People with chronic pain, you know, their pain needed to be at a 6 or lower. Anything above that, they didn't want to have to live with pain that much. I've also had some things interesting in the last few years. I've had people that were very tech-oriented, grew up on games, were very involved in their professional roles in the computer, and the outside world really didn't mean much to them. As long as they could function in a computer world, they really didn't even care if they ate again, got out of a nursing home, or were hooked up to a ventilator, as long as they could use a computer. Well, that's pretty different than what I would go for. So we want to have those conversations. And if you have any of those, they've given you some suggestions there. Excuse me, write them down. And the second one is about time-limited treatments. In other words, yeah, give it a shot. Let's see if it works. And as long as it's working, great, no harm, no foul. But if it's not, and the treatment is worse than taking it away and allowing a natural death, then that's okay too. But go ahead and try it. Unless there's something that you absolutely refuse 100%. And again, we want to be careful about this. And the best way I can explain it, my mother-in-law died last year at 99. And for the last 35 years, she's had a piece of paper that said no IV fluids, no antibiotics, no blood transfusions. But she had chronic bleeding ulcers. And about every 5 years, she'd get real weak. We'd take her to the doctor. Her hemoglobin would be real low. That weak, frail stomach lining would have started to come apart, and she would have had a slow bleed. They'd put her in the hospital, give her a couple units of blood, send her home with a prescription to heal up her stomach and a mild, soft diet for a few weeks, and she'd be good for another 5 to 7 years. She was making her own decisions. We weren't pulling at her DPOA for healthcare because we weren't in that situation. Fast forward to the end, when she was actively dying, just from a combination of really living a long time and a lot of things all coming together, and you're 99 turning 100. No, we're not going to do IV fluids anymore because they won't reverse any of this. And no, we're not going to do blood now because it won't change any of these other disease processes that are going on with her heart and things like that. So no, now it's not appropriate, but back then it was. Maybe with someone with dementia. Yeah, they get a respiratory infection, a few days of oral antibiotic, but if they can't swallow any longer and they're aspirating their own fluids, yeah, that's creating the pneumonia. So maybe we stop treating it because manage their own fluids. It's just going to happen all over again. So maybe it's time to switch gears and be supportive for a natural end-of-life process. So we don't have to say no dialysis, no chemo, no blood transfusions. We can make the decisions based on the circumstances we're at the time, not some global decision. Now, if you're a Jehovah's Witness and it's against your religion to have a blood transfusion, certainly you'd put that on there. Maybe you've watched multiple family members have diabetes and amputations and dialysis, and you say, if it gets to that point with me, I'm never going on dialysis. I'm not going to do it. Okay, then you feel that strongly about it, go ahead. But you might change your mind, and that's okay. Because as long as you're calling the shots, we're going to do what you want to do. This is in the case of when you can't speak for yourself. And that's the last piece I want to talk about, is the do not resuscitate. A lot of people think that the do not resuscitate or the no code status, they see TV, they see the external defibrillators, we put them on the person and shock them. And well, those aren't jumper cables. They don't bring people back to life, okay? When we use that, it's because you have a heart rhythm. It's just beating irregularly and ineffective. It's not doing its job. It's just jiggling around in there, okay? So we shock it to stop it so that it will hopefully resume a normal rhythm. But if I put those leads on there and it runs a strip and says, no heartbeat, resume CPR, it's not going to have me shock a person who doesn't even have a heartbeat. And when we do CPR, to be very blunt about it, the only people that get CPR are people who have already died. Because we wouldn't do CPR on you if you were alive. You have to be dead to get CPR. And if I couldn't keep you alive when you were alive, it's going to be a challenge now that you're not. So we want to be careful about CPR. It's a very, very rough and violent intervention, and we want to do it when it's appropriate. Young, healthier people with a sudden accident, where a few minutes ago you were up walking and talking, but now you've been in an accident. I have something to work with. I can bring you back to the point you were well enough to die. But if that point was like my mother-in-law, I'm not really very likely to bring you back or to do something kind for you. So again, we want to talk about those things and realize that all it really means with do not resuscitate is, if you find me dead, it's okay to leave me that way. Just let me be. And these are conversations we want you to be having with your physicians about your disease process, and as things change, as we age and evolve. And now, if you're over 65 and on Medicare, Medicare pays for your care planning to be part of your annual wellness visit every year, and at no cost to you. If you go in and do an appointment just for advanced care planning, it would be like a specialty appointment, and it would be billed under your Medicare Part B, and you'd have a copay for it. But it can be done as often as needed, and often people are in situations where things are changing every few months or every few weeks, sometimes every few days for a period of time, and then they'll stabilize again. But we want to have these conversations through the years so that when things reach that point, we have an idea, and so does everyone else, of what we need to be doing, and that we have the right documents in place to ensure that the people that need to be able to help us are able to step up and have the authority to do what we need. So we want to think about who your agent's going to be. They talk about that later in the book. What they need to know, how to have these conversations with them, some conversation starter ideas to make it easier to have these conversations, all of those things to help you get through it. The website also has a couple of other resources. There's a Caring Conversations for Young Adults. So if you have people that are 16 to 18 in your room, maybe it's a good idea to let them look at that. They are signing on their driver's license whether or not to be an organ donor, and they're involved in care of the whole family unit. So it's a good time for them to be thinking about these things. And there's one called Courageous Conversations for those that have served in the military. And that one also provides additional information about the aid and attendant benefit for veterans, as well as their burial benefit rights, and some things that are exclusive to a veteran that might not apply to the rest of us. And I want to close it up there because I don't know if you've got any questions, and I want to make sure I leave a few minutes for answering any of those if I can.